Awesome. Good job.
Okay, thank you so much. Peter, John, Rich, congratulations on this incredible worldwide summit. So yeah, I'm going to be talking about some of the tips and tricks associated with duplex scanning for pelvic vein imaging. Now, as many of you know, pelvic venous disorders involves a complex network of anatomy and pathophysiology, and it often contributes to pelvic pain and lower extremity symptoms. So over the next few minutes, I want to share with you some of the common anatomical sites of obstruction and reflux and demonstrate the clinical relevance for diagnosis. Now, with that, here are some of the associated tips and tricks for this exam. Now, for those that do perform this test, you do know it is a dynamic one. It requires time, effort, skill, and patience when you perform it. So for that reason, I like to get these exams done every day by 12 noon. I want the patient NPO and hydrated. And we also instruct our patients to take Gas-X, 2 tabs the night before and 2 tabs the morning of the exam. And this is to help mitigate any bowel gas issues. Now, it's also equally important to, when you're going to go in and do that exam, you got to have a thorough understanding of the patient's history and symptoms and perform a good visual inspection of their abdominal pelvic region, groin, and lower extremity. Again, clinically, this matters. So you want to put it all together, and this is going to help you with what you should expect to find when you're going to do the evaluation. Now, you can appreciate my imaging here on the bottom. These exams require variable positioning through the duration of the exam, and that's despite the fact that many patients have these small BMIs. You still got to get in there, you got to open up the anatomy, you have to elicit reflux, and you got to define and confirm obstructive type lesions. So for any given exam, I'm basically starting in the supine position, and by the time it's said and done, the patient's going to be standing. And please note, I am using everything in between. Again, whatever it takes clinically to answer the question. And with that, I do think that the use of the hydraulic table is paramount in this particular setting. So in terms of imaging transducers, again, the true, pelvic venous disorder patient is going to have a BMI typically less than 25. So you could use a linear transducer. You can create and have superlative image quality across the renals, the ovarian veins, and the iliac veins too. But then when that vessel becomes deep, this is where you're going to need that curved array transducer. Now, there are numerous criteria that we use for pelvic venous disorders. I'm going to take you through some of them. Here, I want to feature the criteria for the iliac vein. So in terms of the direct method, this is where we take calipers. We're going to measure the vessels in long and short axis, and it's based on a 50% diameter reduction. Now, with our pulse Doppler, we also utilize a peak vein velocity ratio of greater than 2.5. Now, when it comes to the obstructive lesions that we see with duplex ultrasound, trust me on this, we see all of them extraordinarily well. The characteristics are very well noted. Now, in terms of the indirect method, there are 7 components to it. All of them are very important when you do this exam, and I am going to feature a few along the way. And I'm actually going to start with one, and one that I think is very important. And this is using the common femoral vein waveforms as a way to detect outflow obstruction. Now, for me, this is the first thing that I do in every single examination that I perform. And it has a high yield to it. Now, my tip and trick here is that with your pulse Doppler settings, you want to make sure that your sweep speed, scale gain, and baseline are the same on both sides, because at the end, what I'm looking for are very subtle and obvious changes in the contour of the wave. And then that is what alerts you to what may be going on above. So obvious asymmetry here in this patient who's 62 years of age. She's got bilateral edema and ankle pigmentation. So here's why. She's got a large mass. And the mass is compressing the bilateral common iliac veins. And since mass compression, here we got elevated velocities here. And this is all due in part to a large leiomyoma. So next, this is an excellent example from a symptomatic patient with iliofemoral DVT. So basically here we can see how the thrombus wraps around the femur head and extends up to the confluence. Now, what's important here is that in approximately 80% of patients with iliofemoral DVT, they are going to have a more proximal stenosis, as evidenced here. And if you look at that posterior wall, you could really appreciate the intraluminal changes that have happened over time because of the repetitiveness of that compression. Now, this is a great example here from a patient who's got left-sided PTS. She's got chronic total occlusion, in regards to the external common iliac vein. So again, you optimize your grayscale, especially the TGCs, so you can delineate the vein walls very well. We also optimize the color scale. We drop it down because the lower you bring your scale, you get more color sensitivity. So my goal here was, number one, to confirm that indeed there is, total occlusion of the entire tract, but also to fill in these collateral vessels and then to follow them through the pelvis. Now, again, we're dealing with basically a 4 millimeter vessel here, and we see it with great detail. And this obstruction actually extends into the distal portion of the cava, where there is a collapsed filter. And please note that the proximal segment remained patent to the renal veins, and as you would expect, a non-phasic flow pattern. Now, this is a great example too. So this patient, PTS on the right, was stented for significant outflow obstruction, right? So what we're dealing with here is basically a missed lesion. Access was gained too high as a result. And again, with that lower color scale, we see the color aliasing here. So you have fibrosis in this area, again, that was missed, should have been covered. You have a velocity here at 200 centimeters per second. Patient is still highly symptomatic, and they were taken back to the cath lab for revision. Now, what I'm demonstrating here is the diameter velocity ratio of greater than 5, as this pertains to the criteria for left renal vein compression. So again, with using your TGCs and your gain, you want to always be able to define the vessel walls very well, because you want to accurately place your calipers. So in this particular setting, what we do is we measure the area that demonstrates that discrete narrowing, right, the obstruction. And then what we want to do is get a measurement on the kidney side where it's grossly dilated, and then there is basically your ratio. Now, in terms of the pulse Doppler portion of this, what we do to insonate stenosis is we get our peak vein velocity caudal to the area of obstruction, and then we get the highest velocity across the area that's maximally obstructed, and then, very simple, we render our ratio. So now let's talk about nivel lesions, okay? So the question with them is it a fixed lesion or not? Now, Nikos has a new paper that's about to be published in the European Journal of Vascular Surgery, and he scanned 100 patients in both supine and standing positions. And when it was said and done and he tabulated the results, he had 68 positional stenoses, and he had 32 fixed stenoses. So let's kind of go through exactly what he did here for those that may be new to this. So here it's 8 o'clock in the morning, the patient's MPO dry and supine, and I'm doing the scan, and I got a vein diameter of the left common iliac of 3.5 millimeters. I do my pulse Doppler exam, and I also, in addition to that small diameter, I have an abnormal velocity and velocity ratio. So the next step here is I now want to turn the patient on their side, or I want to stand them up. So here's the result. So you can see that 3.5 millimeter diameter vessel now has turned to 10 and 11 millimeters, and that velocity that we had that was grossly abnormal has now completely normalized. It's gone. So in this particular setting, right, it's not a fixed stenosis, and this patient was not stented. And just to emphasize this one more time, just look at the positional changes that happen in this case when you're supine to when you go to lateral decubitus, and then when you stand the patient. And I think I'm actually, can't wait to actually get my hands on the final copy of his new publication. And I think that we should all come together, and everybody should incorporate these maneuvers into their duplex scans when it comes to the evaluation of nivel lesions. And hopefully this will end the erroneous stents that are being placed in patients, especially in the young patients that just don't need it. Now, many of us have become very good with duplex in the pelvis, and we're comfortable with going from duplex to venography to IVUS. But, from time to time, we are going to have duplex scans that are going to be suboptimal, and that may be because of the patient's anatomy, or it may be a new learner. But nonetheless, MR and CT are definitely reserved for these particular cases. Again, we need to define the anatomy, effectively before we could offer the patient any sort of an intervention. So let's talk about left ovarian vein reflux. Now, when it comes to that, and looking at the confluence specifically, I like to stand the patient up. I find for me, this is very reproducible. And then when I have the patient standing, I then make a decision whether or not I'm going to advance the transducer, down into the pelvis and document the rest, or I'm going to put the patient on a steep tilt on the table. So here you can see a left ovarian vein, grossly dilated, measuring 10 millimeters, long short axis, has 1 second of reflux. And again, when you have that patient in this position, again, you want to be able to use your Valsalva maneuver or distal compression at the iliac fossa. Now, to take this a step further, if you are insunating this vessel and you see that the flow is more spontaneous in nature and retrograde, then this finding is indicative of left renal vein obstruction. So again, you want to be very diligent when you go from anatomical segment to segment and make sure that you do not miss anything. Now, in contrast to this, if you're insunating this left ovarian vein and you see that the flow is continuous, then you should be thinking about post-thrombotic obstruction. Now, here's the right ovarian vein. Anatomically, we visualize it with duplex. It comes off at the 10 o'clock position. We certainly see cases with isolated right ovarian vein reflux from time to time, and there are numerous causes to it. Now, with that, we also see circumstances where the right ovarian vein becomes grossly dilated, and this is because of compensatory flow coming from the left side and then draining over into the right. Now, transvaginal duplex ultrasound is an excellent imaging modality. You get a lot of great information about evaluating the distal ovarian veins, internal iliac veins, and pelvic varices, as you see here. It's got a 95% sensitivity for pelvic insufficiency. Now, if you're performing this exam and you've become very proficient in it, that is fantastic. If you're not and you're sending your patient out for this exam, you got to be specific to what you're looking for. Make sure they use the color and make sure they have the patient do Valsalva maneuvers so you could see the flow reversal, as was just evidenced in this real-time clip. Now, many of us also perform transpelvic duplex ultrasound. This is where when the patient comes into the lab, we have them drink 32 ounces of water. The distended bladder then pushes down the anatomy so we can then see the pelvic varices with great detail. Again, our cutoff is 5 millimeters and greater. Again, we're going to follow the same thing. We're going to ask the patient, we may change the patient's position on the table slightly. We're going to have them also do a Valsalva maneuver to demonstrate the flow reversal. We also want to make sure that we look for peri and transuterine veins that are crossing over and documenting the flow. Now, another integral part of this examination is getting in there and getting a good look at the internal iliac veins. This is a great example here demonstrating flow reversal. And this is or I should say, due to the fact that there's a left common iliac vein obstruction. So again, at that point, you should be thinking now about the potential, right, of escape points and, flow going through that pelvic floor. So that basically then is going to take you to having the patient stand. So with a linear transducer and having the patient, as I said, stand, right, this technique leverages hydrostatic pressure and an unobstructed Valsalva maneuver to the connections to the pelvic floor and the lower limbs. And this is very sensitive. And remember, these veins lie basically 1 to 3 centimeters underneath the skin. They're very well visualized.